Day. Let's see who's about. It's Thursday. It's about 6 days before the AKT. What I'm going to do is I'm going to shut some doors and hopefully keep the noise down. We'll just hang fire a bit. It's just making sure that everything is coming alive, which it is. Not even 8 o'clock yet. Not expecting many people at the moment because everyone's busy. But I feel slightly biased because the kids are asleep, which, if you are a parent, is the best feeling in the world. But goes without saying that some of them have not been 100%. So if I get a little local interference coming in, then they are adorable. But again, I will try and sort of manage it and deal with it. But anyway, we shall sort of see how things are going. So I'm hoping we get some people who've got about 6 days left before the big exam on Wednesday. The purpose then of this is that you're probably similar to us, as sort of everyone else, in that you're basically just doing questions at this point in time. You're not really worried about learning more information. You're just sort of getting the questions through. So I thought I'd spend a bit of time just sort of rattling through questions and then trying to give the explanation behind them. We'll lean in on the other 20%, sort of the module that I created, and we'll talk through that as well from that point. So the idea of this is that I've not prepped any of these questions, so it's just me giving it a go and just seeing what happens from that perspective. So what we'll do is we'll give it a couple more minutes, see if anyone turns up. I'm hoping we get some firm favourites from last time, as there were some awesome people who turned up, and then we will take it from there. So fingers crossed we'll sort of have a good revision session for an hour or so. Maybe not that long, depending on how many questions I can sort of tolerate and handle. But we'll take it from there. So happy days. Anyway, if you're just tuning in and listening, I hope that you've all had a good day out in GP land, because again, I appreciate it can be tough, certainly if you're trying to study for exams as well as do the day job. But believe me, and I see it in trainees all the time, that actually revising for the exam does, believe it or not, make a good positive impact towards your clinical care. So I'm going to actually stick up for the RCGP and say that actually the exam does make you a better doctor. There we go. I've said it, and it's live streamed, and it's going to go eternally onto my channel. That's that's my thought, and I can sort of testify that from my own personal experience. But yeah, what we'll do is we'll give it till a couple more minutes just to sort of see who turns up, if anyone at all. Teach me for not advertising this session appropriately. But anyway, I'll learn for next time. We're all learning stuff. So thank you for those who have stuck with my live stream sessions. This is session number 4. I've learnt a lot. It has been a massive, massive change in terms of what I've wanted to do and sort of taking the channel in a slightly different direction and seeing if it sticks. But I appreciate it's a Thursday night. You should be listening to Gandalf and the fantastic crew at EGP Learning. So if you're not listening to me, then hopefully you are listening to them, which is phenomenal from that point. So we'll give it a couple more minutes and see if anyone turns up on YouTube. But anyway, if they don't, it doesn't matter. It doesn't matter at all. So I'm going to text my wife back because she's at work. Bless her. Because I don't want to ignore her. So I do this when she's on shift. And we're singing with joy about taking some little ones back to school come Monday. Not that I don't love them to bits, but you know what? It's been Easter holiday. And yeah, they need to go back to school. Anyway, so we'll hang fire. We'll give it a couple more minutes. So what we're going to do is we'll go through just a short presentation just to sort of give you a bit of a background of this. And then we'll end up going into the RCGP self-test. And then hopefully that will sort of give an idea of what's going on from that perspective. I hope that everyone is revising going well and that you've got sort of like the last weekend of cramming and revision. And then big day in a couple of days, and I'm hoping that your training program has been kind to you and your whatever practice you're at has been kind to you, and that you've got a little bit of time just to mentally get yourself prepped and prepared for this. But anyway, doesn't matter. Is what it is. And we'll take it from there. So we'll give it a couple more minutes and then we'll crack on with this. So, or should we just start? Don't know. It would be nice to have at least one person. But hey ho, beggars can't be choosers. So we'll give it till 5 past, just in case anyone is putting their children to bed or trying to get their dinner. I've done one, not done the other. Having a quick snack just to make sure I don't get completely hypoglycemic by the time I'm sort of talking through these questions. And then we'll take it from there. If you're on LinkedIn and you love all the stuff YouTube, check out Joe Watkins. I'm going to give a masterclass or give an hour chat on Dave on YouTube, which will be very, very fun. I absolutely love Joe Watkins to bits. Check out her podcast, please, 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 called The Doc Sports Surgery, looking at doctors who are going into business and how they've sort of set themselves up doing something a little bit extra. I think as well, you've got to be mindful of, a lot of these clinicians are doing what you'd seem as a typical NHS job, but they're often doing something a bit extra on the side. And it's something that I see more and more often, myself included on that, hence the channel, hence teaming up with Doc Sport and becoming Doc Sport. But yeah, we'll take it from there. So nuts to it. Let's go for it. It's 5 past 8. If you're watching this late, very, very best of luck to your AKT. What we're going to do in this sort of next probably 45 minutes to an hour, depending on how much brain power I've got at the left of the day, and then we'll take it from there. So the reason why we're doing this, and it's a fair question to ask, and why the heck are you doing this, Dave, and sort of spending your evenings chatting down on a microphone to try to help others, is because I got very, very frustrated at AKT. So this is my AKT back in 2016. I'm showing my age. Yes, I'm fastly approaching 40, which is mind-bogglingly scary. But anyway, so this was my exam. So I got 65% of the clinical, which is awful, 80% for the stats, so the evidence interpretation, and then 75% for the admin side, okay, which basically was just a scrape fail, okay, but I'm glad I failed because it made me look at the clinical for whatever good it did me, but then suddenly I seemed to absorb even more admin and stats, but thankfully I passed. Happy days from that day, only just though. So what I took this as is that as I went on to my GP career and as now a GP trainer, is that more and more trainees basically turned around and said, I struggle with the stats and the admin, I don't mind the clinical, especially my 2 international graduates who are phenomenal, but I coached them through last year and thankfully they both smashed the July sitting last year, and it's thanks to them that 20% was born. So Do not do what I did. Please go and revise lots of clinical, and then make sure that you just minimize the time to your admin. Okay, so because of that, I set up the other 20%, and I've got the April Smash, which for £30 you will get access to 16 modules, 10 on statistics, 6 on admin, which I believe is probably the core of what you need to know to get you a decent mark. Fingers crossed from that way. So as you can see here, it's hosted on Kajabi. It's got a whole load of questions in there as well, numbering about 100. So if you just want to revise the questions, then you can smash through that from that point. As said before, I'm part of Doc Support. So myself and Matthew Wickham, who's a GP who I went to med school with, we sort of combined and formed Doc Support. And basically what we're trying to do is to create a platform and a base that for other doctors who want to do something different, have basically somewhere to go to so they can lean in and help out from that point. There are regular webinars, and there is a decent website which has got a whole load of free resources. Go and check those out. So docsupport.co.uk, a couple of ebooks on there as well, and basically the upcoming webinars. Now, I know the April the 15th has passed, but that was a fascinating session looking at CQC compliance and a load of people asking a whole load of questions from that way. And then the 29th, which is next Tuesday, about setting up your private practice. Okay, and this is from Matthew himself, who set up his own private practice and has done phenomenally well. He's got a beautiful work-life balance, something that, you know what, hats off to him. He's done so well with that. And actually, it's a pleasure to sort of join on and support him from that way. So what we're going to do is let's stop sharing the screen. What we're going to do is we're going to head over to the RCGP self-test, okay? And then what we're going to do is we're going to share that screen. So you should see the RCGP self-test. And then what we're going to do is we're going to do topic specific. And then I'm going to prove, he says, whilst what we're going to do is I'm going to sign up, I'm going to get into Kajabi as well so I can get to the back end of the course so that we can sort of see how we're doing from that point of view. So courses wise, bear with me whilst we get this set up. And what we'll do is we'll then lean on, so when we're struggling with difficult questions, we know where to look in the course, because sometimes it's not obvious, okay? So this is what the course looks like. So this is once you've all signed up. This is hosted on Kajabi, which is a phenomenal platform and has been very nice to use. And as you can see here, you've got a couple of lessons. So mastering the statistics, lesson 1, 2, 3, and then a bit of statistics knowledge questions, sensitivity and specificity, screening, etc, etc. Thank you very much to those who have already sat the course. They've highlighted some errors in the questions, my fault, no one else's, which have been corrected as of this afternoon. So a huge thank you to them, who are my fantastic guinea pigs going through this. So you can see this, that you've got a whole load of bits and pieces for this to go through, okay? And I will be adding more to the course as we go through. So without further ado, let's share this tab and have a look. So let's go with, what are we going to go with first? Shall I be kind to myself? Let's be kind to Dave, because it's been a long day. So let's start off with, where's the admin gone? Or should we go evidence-based? Let's do some stats. What do you reckon? Let's do it. So what we'll do is we'll do the stats session and then we'll take it from there. Cool. Right. So population pyramid, love it. Represents the population in your practice compared to other practices within your CCG, clinical commissioning group. Just be careful that the CCGs, I'm not sure they technically exist anymore, but sort of ICBs is the integrated care board. So basically a large area which sorts out for it. Okay, so let's zoom in if I can. It might not let me. I love my Mac to Bix, but sometimes it can be a bit difficult. So let's have a look at this. So what we've got here, so this is looking at how we can deal with a graph that you may not have revised or that you may not be conscious of, and how we can sort of tackle this. Okay, so let's orientate ourselves and give us the information below. Okay, so it represents this. So you've got practice male, practice female. So you've got males in the dark blue, females in the light blue. So right hand side for females, dark blue for males, and you've got them in age groups. And looking out about here, it's about every 4 or 5 years. So like 45 to 49, 50 to 54. Okay, so and then 95 plus. And you can see here then percentage of total population. So you can see here that you've got average sort of, or the population of that group at any particular time. And then you've got two lines here. You've got the CCG, so imagine a huge, large area. And then you've got England, okay? So you've got CCG will, let's take ICB, for example. So I'm in the northeastern Cumbrian ICB. So that covers, if you imagine I'm northeast of England, so that covers really sort of Newcastle up to about the Scottish borders, all the way across England, and then down south, probably about as far as be about Northallerton area. So quite a large sort of area from that way. But to put it into context, it's not as big as England. So just be sort of mindful of that. Now with this, now we've orientated ourselves on the graph. Let's go through each of this, okay? And then basically analyze each question individually and say whether it's right or wrong, okay? So there are fewer pensioners over the age of 65 in your CCG than the national norm, okay? So 65 you got here, and they're saying they're fewer. Now, blue is the national norm, okay? Registered in your CCG, then they're saying there are fewer. Now, that's greater on that side and greater on that side. So incorrect. There are more teenagers registered in your CCG compared to the national norm. So teenagers, so under the ages of 20. So you've got your CCG pink line, and again, the answer is new. There are fewer people aged 25 to 35 registered within your practice than the CCG norm. Okay, so your practice is actually the dark blue line. So 25, there are fewer. No, it's more for males and more for females. The mode age of your practice is 15 to 19 years. So mode or modal group is the most common occurring group. Okay, so you can see it from this way. Basically, it's the percentage that sticks out the most is the easiest way to think about it. So that's 30 to 34 on this side and 30 to 34 on this side. So new. The mode age for your practice population is 30 to 34. And guess what? We've just sussed that one out. Okay, so what we're doing is we're combining certain previous bits to then look at how we're going to talk through the actual examinations themselves, okay? So what I'm going to do is with regards to that was more about how do you answer these weird and wonderful stats bits. And what I like to put is call it picture stats, or sort of like ice the stats from that way. I've got a whole module about basically how I isolated the diagram, identified the information, critique the question, then add a clinical knowledge, bit of common sense, and evaluate each answer individually and eliminate the incorrect answer. Okay, so got it right. Next question. Ooh, numbers needed to harm. Okay, cohort study. So we're looking at relative risk. Study established the link between smoking and death from lung cancer in males assembling plant factory workers. Results are summarised in the table below. What is the appropriate number needed time for smoking and lung cancer death? Select one answers only. So, right, what we're looking for is the right, smoking and death. So we need to find, let's have a look. I've got trusty pen and paper. So we're looking for the control event rate, and we're looking for the differential between the two. Okay, so deaths from lung cancer and deaths from all other causes. Okay, so the bit that we want is the actual rate in the group. Now be careful, I'm going to hopefully get this right, is that you want to do the deaths from lung cancer from basically the smokers. Let's have a look. Let's make sure I get this right, just so I'm not teaching you all bad habits. So death from lung cancer. So basically you're looking at smoking, so we're going to go across the way, but be mindful we want the rate. So it's 3,000, but it's not divided by 2,400. It's divided by the total of that. So it's going to be 3,000 divided by 2,700 or 27,000. Okay. So bear with me whilst I suss that out. So that's 3.11 recurring. So that is your rate within the smokers. So again, likewise, we're going to do the same again for the bottom. So it'll be 100 divided by not 20,000, but 20,100, okay, to get the rate divided by that, okay. That's equal to 0.00, we'll say 5, okay. So 0.005. Now we want the difference between the two. Okay, so it would be 0.11 minus 0.005. Minus 0.005, which equals 0.105. And then so effectively we've got the differential rate in terms of what's causing this, and then we want the inverse of this, so 1 divided by 0.105, okay? So 1 divided by 0.105, which is 9.5. Have we got a 9 or a nearabouts? Okay, so we've got a 9 down there, so that's what I think the answer is, which I'm deep sigh of relief. Okay. And we're going to check this. Please be right, otherwise I'm going to cry. Yes, there we go. Right. So they've got exactly the same here. Okay. So 3,000 divided by, here we are, 2,700. As I said, 100 divided by 2,000. And you want the absolute risk increase. So the difference between the 2.0. Okay. They've got 106. They rounded up. And because of that, they got down to 9. So happy days. Good work, team. Research is looking at the management of moderate hypertension, divides its subjects into 2 groups. Group A with 1,776 subjects receiving antihypertensive. Group B has 1,800 subjects receive a placebo. After 5 years, the risk of stroke in Group A is 12%, while the risk in Group B is 20%. What is the numbers needed to treat? Now, they're being cheeky. Okay, so you can work out the numbers needed to treat because it's the difference in the percentage. Okay, the risk of stroke is in Group A is 12%, while the risk in Group B is 20%. So instead of getting overexcited, and you can ignore how big the subject group is because they've given you a percentage. Okay, so 20% minus 12%, okay, equals 8%. Now, 8% written as a decimal is basically divided by 100, so 0.08. Okay, so once you've got 0.08, what you want to do is do the inverse of this, so 1 divided by 0.08, okay, which off the top of my head, I don't know, that's why I got a calculator, is 12.5. So round it up is going to be 13. Thankfully, there's a 13 there. I wasn't worried, you were worried. Here we go, we got it right. Phew. Reciprocal of the number is 12.5, implying the doctor would need to treat about 30 moderately hypertensive. Boom. And they've done exactly here. So 20 minus 0.012, so they've converted it from a decimal, from a percentage into a decimal already, and then done the reciprocal. So when you say reciprocal, that's 1 divided by the difference there. Happy days. God dear. Right, okay. Oh, you blighters. Right, okay, I know exactly what they've done here. As part of a local study, the urine culture were collected for all primary care school children aged 4 to 12 years, and the study results are summarised in the table below. Number of samples examined, number of significant bacteremia. Okay, so what you've got here is that what is the prevalence of bacteremia in this group? Okay, number with significant bacteremia, number of samples examined. So basically what you're looking at is you want basically the 20 divided by 800 and see what the percentage is from that way. Okay, so 20 divided by, because it's a snapshot in time, so we've got 0.025, but again we want it as a percentage, so we multiply it by 100 and that's 2.5. We've got 2.5 there. There we go. Prevalence of the urine is calculated, basically those with a significant, so 20 divided by 800, which is 2.5. Marvellous. Which one of these following conditions is most likely to follow a bimodal age distribution? Select one only. So bimodal means bi is two, think bicycle. Modal as in two distinct age groups. So do you know of any groups or any sort of conditions that present, say, in a young age population and an old age population? Is probably the classic one. So let's go Hodgkin's lymphoma, maybe, because actually you get young children with Hodgkin's and then get it later in life. Pityriasis rosacea, don't know, or rosea, sorry. Carcinoma of prostate, absolutely not. Bronchiolitis, absolutely not. Osteoarthritis, absolutely not. These are all generally older populations, so it will be a single or just a one mode group from that way. So we'll just go with Hodgkin's and see what they say. Fingers crossed. Here we are. Bimodal. Two peaks of instance. The age in so late 20s and the second peak age after 50. Boom. Oh, right, here we go. See the following figure in a clinical article at your monthly journal club meeting. Oh, which is the single most appropriate description for this figure? What is this? It's a forest plot. I can't say it anymore. It's what it is. It's not Boston whisker because that's with the square and the two bits either side. Normal distribution is your Gaussian. Population pyramid is what we saw actually in the first question. So with that funny sort of bits and pieces. And it's not a funnel plot. I can't think what a funnel plot is off the top of my head. Oh, I'm going to have to Google it just for the sheer joys of statistics. Do love my medical statistics, probably a bit too much. Is it because it is a funnel plot? Oh my word. I apologise, ladies and gentlemen. Forest plot's not that. Forest plot is with your meta-analyses. What an idiot I am. I do apologise. It's a funnel plot because it looks like a funnel plot. Normal distribution, what proportion lies within two standard deviations of the mean? Select one option only. Okay, so... or any pedants amongst the room, which I love you, will know that the right answer isn't there. But for the sake of this exam, it is 95%. Lovely. So actually, it's 1.97 standard deviations of the mean accounts for 95% off the top of my head. If you used two standard deviations, it's just over. There we go. Oh, I'll adjust my nasal steroids. Thank you very much. Odds ratio. The following results were gained from a case control study exploring the relationship between occupational exposure of human HIV and subsequent seroconversion with and without antiviral prophylaxis. From these results, which of the following statements is correct? Oh, so they don't want me to... Oh, okay, right, fine. Do we want an odds ratio? So prophylaxis given, yes. Number of cases is seroconverted. Numbers of cases did not seroconvert. So do they want us to calculate a rate? Let's do it anyway. So just remember, it's going to be 8 over... Oh, this is where I get... This is where... Let's not guess. It's a good lesson. So we're going to go to module... What are we on? So that is a odds ratio. So that's going to be a cohort. And it's a cohort study. Here we are. We're going to calculate relative risk. So we've got the exposed rate, not exposed rate. And it is. We're similar to as we did beforehand. So you're looking at the total of that line from that way. Okay, so let's go with this one. So we're looking at the rough rates. It'll be 8 divided by 168. Okay, so let's sort of work it out first. So 8 divided by 168. Is 0.0476. And then again, likewise for the prophylaxis given, no. So it'll be 20 divided by 220, not 200, because you're looking for the whole group. Okay. And that's 0.09. 0.091. Okay. So what we're then looking at then is the ratio between the two, sort of looking at, so that would be 0. So it'll be the prophylaxis given. Yeah, so the exposed rate, so yes, divided by that, so it'll be 0.0476 divided by 0.091. Which equals 0.5. Oh, the cheeky blighters. So they wanted us to work it out because the odds ratio for seroconversion is 0.5. Okay, well, I think what they wanted to do is that basically you try and sort of go that way. So let me just check it's right before I get... Yeah, there we go. Got it right. Well done. There we go. Good work. The power is determined by which one of the following calculations. Oh, that is mean. Power. I actually don't know. The power of statistical study is determined by which one? I thought it was 1 minus a type 2 error. There we are. Q. Type 1 error, rejecting the null hypothesis. Type 2 error is failing to reject the null hypothesis. So if it's a study is appropriately powered, basically think if you've got more sample sizes, bigger sample size, better study, etc., then that sort of shows all the best from that way. Okay, so happy days. Screening test. New protein TUM1 is proposed to identify patients at risk of carcinoma of stomach. Oh, you're going to get me to do some sensitivity or specificity work. Gastroscopy has been used as the gold standard to confirm the presence or absence of the disease. Initial pilot studies have been revealed showing the following results. Okay, so really, really good question. Okay, so what you're looking at is then basically if you imagine in time in the study actually, and they tell it whenever you're dealing with sensitivity, specificity, positive predictive value, negative predictive value, you are having a simple test. So in this case, TUM1, and the gold standard of whatever you're going to find it. So whether it's a biopsy, a CT scan, examination, whatever, or something that actually definitively shows you, not examination, ignore that, that's your simple one, something that definitively shows you that something is there, that is then going to be what's compared to. So you want your specificity, so we're going to pop over to the sensitivity and specificity module for this, so bear with me while we do this. We're going to go down. So this is the sensitivity and specificity module. So we've got it all set out. Very nice. They want specificity, so that's true, negative. Over that way. So we're going basically this column here, which is very, very easy to do. Okay, so we've got this column. So we're looking at the negative results, would be 180 divided by 180 plus 20, which is 180 divided by 200, which off the top of my head is probably going to be pushing around 96%. So it's 90%. I'm glad I checked. Yes, there we go. It's almost as if I've written a course for this. Next. I hope you're finding this useful. If you are finding it useful, please like, share and subscribe. 3 call to actions. Very bad form. Anyway, which single definition best describes the positive predictive value of a test? Select one option only. The proportion of those who test negative who do not have the disease. The proportion of positives who are correctly identified by the test. Ding. The number of patients who must be treated for one to benefit, that is numbers needed to treat. The proportion of those who test positively who actually have the disease. Or when you're talking with the disease, that is sensitivity, the proportion of true negatives correctly identified by the test. That is, crumbs, specificity. Wait, proportion of true negatives correctly identified by the test. No, that's negative predictive value. Oh, man. Did I just get sensitivity wrong? I do apologise, ladies and gents. Can't be 100% perfect. So that is... Oh, damn it. Excuse my profanities. The proportion of cases with positive test who have the disease. Oh, positive predictive value, true positive correctly. That's sensitivity. I do apologise. Blast. Silly Dave. Proportion who have a positive test. Oh, you silly sausage. It's been a long day. That's what I'm going to blame. Colleague asks about global international exchange programs who on offer beyond Europe to GP registrars and GP within the first 5 years of qualification. What's the single most appropriate? What the heck is this? Okay. Hippocrates, Family Medicine 360, Erasmus, an offer beyond Europe. I haven't got a clue. I'm going to go Erasmus only because my wife went on Erasmus. And that's the only one I know. It's not that. Right. I've got 2 wrong. Family Medicine 360. Really? Why is this in the AKT? Okay, come on. What? Next question. Let's just move on. I got it wrong. You attend a locally run diabetes update course where a recent randomized control trial is presented. Which one of the following figures would best illustrate the flow of patients through the trial and reasons for the attrition and dropout? Or, so, population pyramid, nope. Run chart, don't know what that is. Consort diagram. Now, on the top of my head, I think it's that one. Funnel plot, I've already got that question wrong. Population, and it's to do with meta-analysis. Population pyramid, nope. Histogram, nope. That's just a fancy term for a bar chart. So it's either run or consort. I want to say it's consort, only because I had to give, consolidation standards of reporting trials. So this is a standard format, and it's that blocky one where it says, like, we recruited these, and then da-da-da-da. Anyway. Oh, you have a protected learning session coming up. Oh, and you promised to present information about prevention of strokes in patients with non-valvular AF. Oh, whilst presenting your presentation, you look at information about the benefit of DOACs compared to warfarin and find the following information. Amazing. That's what you find overall. So, favours DOAC, favours warfarin. Okay, so what is this? Stroke and systemic embolic risk. Okay, from the following information, the forest plot, which of the following treatments is true? So let's orientate ourselves. So we've got the one, which is the no effect line. So you've got favours warfarin on one side, favours DOAC on the other side. One means either way, doesn't, or as in it doesn't matter. Okay, your diamond is basically your overall. Okay, what sort of goes with it, and heterogeneity is whether the studies are similar enough or have they been analysed to be similar enough to basically match. This line of no effect means that if any study touches it, technically it's not statistically significant. You can say it favours either side, but you cannot say it's statistically significant. Okay, so and if it's clear of the line, so only with this one, then it is statistically significant. So from these 4 studies shown, you can state that overall they favour DOACs, and because it's clear of the line, that overall it's statistically significant. But 1, 2, 3 studies aren't statistically significant, though they do favour DOACs, and 1 does favour DOACs and is statistically significant. There. The other bit to know is about to do with the power of the study, and basically that you can ascertain that from the size of the square. So the bigger the square, the better the study, in short. Okay, so big chunky squares, teeny tiny squares, and you can see it with the total patients that actually that sort of roughly mirrors those sides. Okay. So select one more. All 4 of the 4 trials used in the meta-analysis showed no significant difference between meta-analysis. I've already said 3 of them don't, 1 does. The heterogeneity is significant. So, oh crumbs, I want to say that's correct. I know there's a cut-off, and I do apologise, I don't know off the top of my head. The risk of bleeding is greater with DOACs than on warfarin. Strokes and systemic embolic risk. Favours DOAC, favours... No, we don't have that information. Overall, warfarin is more effective. Nope. Overall, DOAC's more effective. Check. I might have got B wrong. Oh, no. Hazard ratio 1, blah, blah, blah. Does it go on about I squared? No. There we go. Bit of a longer one. Anyway. Department of Primary Care at local university wishes to investigate whether to use proton pump inhibitors increases the risk of osteoporosis. What's the single highest quality study to use? Now, hands up, I've answered this question before because I thought single highest quality. Well, meta-analysis is the single highest quality. No, but that doesn't take into account of the location. So you're looking at a primary care setting, local university, so you've got a local population. So what you're going to do is you're going to cohort them into different bits. Or are you going to case control? You are going to, I'm going to stick with my first answer and say cohort them. Yeah, I'm going to cohort them. I'm going to get it wrong, and I do apologise. I told you I got it wrong. Blast. You are a silly sausage, Dave. So what are they saying for? Cornerstone of evidence, blah, 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 blah. Systematic reviews, randomised controlled trials. Have I missed randomised controlled trials? Did they give you the right answer? Cross-sectional studies. I don't actually know. That's a bit mean. You can't do a meta-analysis on that. You haven't got the information. RCT, you don't have a randomised controlled trial, so it's cohort as the next one. I disagree with you. But anyway. What do I know? Apologies. Right. Next. Risk ratio. Research the 50 obese women and 50 women with baseline body mass index less than 30 for 5 years. Group in obese women, 5 develop type 2 diabetes during the type 1 person develops in the non-obese group. So let's go back to our ratios. What's the relative risk ratio of developing diabetes? So we got the event rate of 1 over 1 divided by, what am I thinking? So it's 50 and 50. So it's basically 5 divided by 50, which equals 10. And 1 divided by 50. That's wrong. Got 0.1. Apologies. 5 divided by 50 is 0.1. 1 divided by 50. 0.02. So 0.1 divided by 0.02. Which equals 5. 5, please be there. It is there. Boom. Done. Forest plot. What's the name of the following bit? Now, this is a forest plot. Am I going to get it wrong? No, I'm not. Here we are, 2 standard deviations. New biomedical marker is being used to screen for prostate cancer. Please be better than the current one. To estimate the reference individual for population, 1,000 blood samples from male individuals whose blood were taken. The reference interval was set to 2 standard deviations above the mean. Okay, cool. Lovely Gaussian distribution. Which one of the, or normal distribution? Following for the statements about the new biomedical marker is true. Once the reference aims have been determined, it will always remain the same. Nope. Serum concentrations in test population are not normally distributed. Disagree. They sort of are. You've drawn a nice picture. Mean serum concentration in the normal population is 0.3, so 0.3 there. Peak, so mean, medium, mode is all the same. So that is the middle and it's 0.3, so that is correct. The normal range is 0.12 to 0.48. No, because that's the extremes of that. Blood samples from 95% of the population without prostate cancer will fall outside of the reference interval. Blood samples from 95% of normal patients without prostate cancer will fall outside of the range. No, that's the whole point. This is normal population. Oh, crumbs. They're trying to be cheeky. There we go. Next question. Which one of the following general practices require approval by Research Ethics Committee? GP registrar conducts a patient satisfaction survey. Nope. Practice implements a new policy to switch to a newly licensed cholesterol-lowering agent, tricle stop for all patients with diabetes. It's newly licensed, so it's been through the research, so it's not that one. Practice participates in a regional trial comparing the efficacy of acupuncture with oral ibuprofen acute lower back pain. So that will do, because it's a regional trial. Potentially, patient sends out postal questionnaire asking patients' opinions regarding new online appointment systems. That's just getting feedback. Local CCG conducts a telephone survey regarding alcohol consumption. The results compared to practices within CCG. Again, that's just local data collection, because this you're actually doing scientific research, and you're trying to compare the two from that point. Okay. So, next question. Lead time bias. When evaluating the effective physical screen test, how does lead time bias affect mobility and mortality? Okay. So what the issue, I've got this right. It's under the screening test. So they're talking about the Wilson-Younger criteria. So effectively, lead time bias means that it has no real impact. He says off the top of his head. There we go. Boom. He's going to finish the attempt. How did I do? Oh, 85%. I'll take that any day of the week. Right, what we're going to do, we've got, how long we left? We've got 20 minutes left before I'm going to go and get my dinner. We're going to go on the admin one. Leadership and management? Nope. Nope. Is it that one? Not sure if I've already done this. Parental leave. Crumbs, I have done this. Which one of the following statements is true regards as entitlement? Crumbs. Parental leave. So it must be taken. Prior. So this is unpaid leave. Each payment taken up to. I've got this wrong. I know I'm going to get this wrong. What a great way to start. I'm sure this is one where you can take it up to a set period of time. I think it might be C. Moment of truth. It's the spinning ball. Come on. Blast. Parental leave, unpaid up to 18 weeks, up to their 18th birthday. Blast. Named, not self-employed, not a foster parent. So which one is it? Statutory. Unpaid time off work. So it's not that. It's not that because it's unpaid. Up to 6 weeks. 4 weeks for each child. Nope. Qualified to 2 years continuous work. Is it that one? Statutory parental leave is unpaid. Oh, heavens. What? Oh, it's right sneaky at the bottom. Deep breath, Dave. Deep breath. It's fine. Complaints. Oh, right. So, 23-year-old man, he's seen in A&E, was diagnosed with viral gastritis, and now he's going to complain. He wants to make a complaint and demands financial compensation. So this is not your department, not your problem, not your circus. Advise him to contact a solicitor. Nope. Advise him to contact PALS. Yes. Advise him to contact GMC. Nope. But extreme. Advise to contact LMC. So that's the local medical group from that point. Advise him that it was unfortunately develops. Nope. But it is PALS. So patient advised liaison service. Not your problem. You do not need to do anything from that perspective. Happy days. Next question. Practice nurse at your work recently complained. So she works for 3 hours per day between 9:30 and 4:30. So 9:30, 10:30, 11:30, 12:30, 1:30, 2:30, 3:30, 4:30. So she works 7 hours in the day. I want to say she's entitled to... Is it 20? No, I remember it's actually legally, it's really brutal. Is it 20 minutes? Yeah, 20 minutes. Oh, blast. Okay, apologies. Rest period, they apply under the regulation, uninterrupted rate when working time is more than 6 hours. So I do apologise. 20-minute break. No. Practice most knowledge and complaint. 3 days, all day long. 3 days. It's very limited in what they can do and ask you with regards to complaints. So the answer is 3 days. A patient can make a formal complaint within 12 months of an incident or 12 months of them becoming aware of incident. That's incorrect, okay? Well, they clarify this. This time limit can sometimes be extended if there's deemed to be valid reasons in delay or in reporting the complaint. or if there's a significant reason why they've delayed it. So, or if it's a significant complaint, i.e. if there was sexual harassment, for example, from a medical professional to a patient, and they felt so mentally aggrieved that they couldn't do it within the 12 months, that would still be upheld. Okay, so ignore that, because the nature of the complaint so serious is that 12 months is washed. Okay, so be good. Okay, 50-year-old man is applied for medical insurance. He reveals a diagnosis of myocardial infarction that he suffered 1 year ago. He wants to remove from the records. So basically, it's saying that he has got MI, but it's having a massive impact on his medical insurance, and he wants it removed. So basically, he's asking you to lie for him. So guess what the answer is going to be? Removal of the diagnostic code for MI until the patient obtains. Nope. Remove the consultation and hospital letters. Nope. Remove the diagnostic code. Nope. Explain the diagnosis cannot be removed from the medical record. Correct. Remove the patient from the practice list. So we're aware that we can't remove it from the medical record, so we know that's right. Remove it from the practice list. Though patients may annoy you, it's not good enough to get them to not go away. Which of the following items do not contribute income to the practice? So DES, that certainly does. QOF certainly does. Home visits to registered patient, that does not. Locally enhanced services, that does. Global sum, so how much how much money you get from all the people, certainly does. So it's home visits, that is part of your core contract. That's stuff you have to do, ladies and gents. According to the NHS complaints regulation, what is the time limit for practice and acknowledge a complaint? So that is acknowledging 3 working days. Boom. That is not dealing with the complaint, because if you imagine some complaints are really easy and you can deal with either that day or maybe a day or so afterwards. If it's longer and more in depth, then actually you need to be, there needs to be more work to it. So there's no time limit set. Though you would argue, though, in terms of dealing with good business, that actually you want it as quick as possible. Practice starting offering extended hours and now doing from 7 till 9. As a result, practice managers has reviewed the adult staffing levels. Employees are entitled to break for how many hours between working days? So think back to your A&E shifts. I'm showing my age because I know it was 11 when the BMA contract came up. There was a massive hoo-ha because certain shifts, there was not 11 hours between them, and it was exhausting. I know if there's some old and bold listening to this, you're going to just hear me cry and go, where, or something equally as supportive. But Halo. Which one of these is deemed an essential service? So what does your practice offer? Okay, so travel vaccinations, nope, not every practice offers. Non-specialist care of the terminally ill, yes, we do offer that. So we are non-specialists. I'm not a palliative care doctor, though I will go out and see patients who are end of life. Smoking cessation, nope, I'd send them away to somewhere else. COVID-19, you don't have to do it, though financially you'll be... or would you be foolish not to do it? On the borderline about that one. Weight management services, nope, all externally dealt with from that point. Boom. Prescribing error occurs and patients given incorrect medications, and they say discover, which is a standard time limit for a patient to make a complaint about an adverse event. Now, okay, 1 year is what they're going to say as the right answer, but just be mindful that if it's serious, it can be longer. So that was a medication error. You think, meh, fine, but just be careful that actually if someone then said, no, I was mentally massively affected by that error. Anyway, so we're wanting access to medical records. How quickly do they need to give it? And that's within 28 days. Boom. Which of the following regulations governs the use of personal data? So that you've done all your annual bits, you know you've had all those pesty emails saying, can we keep your information? And that's GDPR, because that was introduced, I believe it was 2015. Oh, 2018. Oh, blast. Clearly not good enough. She wants to make a complaint. Guess what the question's going to be? Practice must acknowledge the complaint. Check. There is a gradual theme towards this. Oh my word. Same thing again. There's only limited bits. 3 working days must be acknowledged. Sorry, I shouldn't skip through that. 43-year-old gentleman presents at reception. He's possible chest infection, no proof of address. So he is homeless. He is very vulnerable. So be nice. Pick the nicest one. Register the patient as temporary. Meh. Refuse to register. Nope. Advise the patient to register at local emergency department. No. Be nice. Register the patient using a temporary address or the practice surgery. Advise him to register at another GP surgery. So register the patient at temporary address or your surgery address. Okay, So that's the nicest thing to do. Just be nice. Speak to a 55-year-old man who's recently been discharged from hospital following a stroke and has a right-sided hemiparesis. Prior to the stroke, he was fit and well. He asked for your statements of fitness to work. You issue a certificate that he is not fit for work. What's the maximum length of time you can issue the certificate for? There isn't a maximum length of time. This is wrong. Were they going for, I think 3 months we get sniffy about, but technically there isn't. Oh, okay. Here we are. Okay, fit note can be issued for no longer than 3 months. After the first 6 months of incapacity, a fit note could be issued for any clinically appropriate period of time. Oh, got that wrong. Which term best describes local NHS GPs elected and appointed local to represent the interests of GPs and health authorities? So that's the local medical committee. So they're a group of GPs who sit there and will fight your corner and give guidance in terms of new things coming up. For example, the rise of Manjaro and requests for Ozempic and all the GLP-1s is going to cause a huge impact. But it will be useful to get a group of GPs' opinions rather than just every practice doing it very, very differently. So the health board, nope. Local area team, nope. Integrated care board, so as I said earlier, that is a large group of people. GP Federation, nope. That's an external, normally company or group who will often enhance or take up certain contracts for you. A man attends your practice as a temporary resident. He usually lives outside the area, staying with his mother. She's convalescing. Okay, which one of the followings? So, TR1 would be your obvious one because you're like, temporary resident, let's go. So, it's GMS. So, it's GMS 1 is if you're full time, and then GMS 3, don't know what these two are. Boom, done. Next question. Which one of the following organisations is revalidation? So basically, revalidation falls under the General Medical Council. So you are fully registered on the General Medical Council. As soon as you get fully qualified, that will then go to, you'll get an appraiser and they feed back to the General Medical Council. Under current guidelines, how often are licensed GPs required to undertake revalidation? So it's every 5 years. So you either know it or you don't. So that means you get an appraisal. So an appraisal and revalidation are different. For appraisal, it's every year, and then revalidation's every 5 years. So basically, as part of that, you need to make sure you've got an appraisal for every year. If you're a GP registrar watching this, or trainee, sorry, you will automatically fall under that because effectively your training supersedes this. So if you've done F1, F2, GP, ST, 1, 2, 3, your revalidation will probably hit at the end of ST3. You won't need to do anything really because you've been in training, and as long as you've kept up with your portfolios and they've been automatically submitted, chef's kiss. If you're taking time out of training, just remember that your FY3, 4, unless they are an official training bit, you will need to have a separate appraisal, okay? And that will mean that they have to have that. So yeah, anyway, finish attempt. What did I get? Boom! You know what? I'll take that any day of the week. So, that's it. We'll end it there, really. Just to say that if you're sitting your April exam, you've still got time over the weekend. I'll leave the QR code up to there. That will take you over to courses and modules that you can sort of smash the revision through from that. If I don't see you, or if you're already on the taking it, very, very best of luck to you. Okay. Good luck if you're taking it, and I hope to see you on the other side. I would love to hear how you got on, and good luck for next Wednesday. And have a wonderful, wonderful evening.